Welcome to today's VJHemOnc podcast. We recently attended the 3rd International Workshop on Myelodysplastic Syndromes and Myeloproliferative Neoplasms in Lisbon, Portugal. This event brought together the world's leading clinical researchers in MDS and MPNs to share their perspectives on how to place the evolving understanding of these hematologic malignancies in a clinical context to optimize clinical care. This podcast features a discussion from the meeting with experts Amer Zeidan, Elizabeth Griffiths, Lisa Pleyer, Andrew Brunner, and Yasushi Miyazaki. They begin by summarizing the key themes from their presentations, which cover a wide range of hot topics, including the role of allotransplant in Japan, communicating about drug efficacy in clinical trials, validating response criteria, and optimizing the use of hypomethylating agents. They then have an insightful discussion on how we can enhance clinical trial design and ultimately improve outcomes for patients with MDS.
Hi everyone, my name is Amer Zeidan from Yale University, and it's a true pleasure to be speaking to you here from Lisbon, where we actually just concluded our 3rd international workshop for myelodysplastic syndromes and myeloproliferative neoplasms.
Hi, my name is Elizabeth Griffiths. I'm at the Roswell Park Comprehensive Cancer Center in Buffalo, New York, and I've been really pleased to participate in this excellent meeting.
Hi, my name is Lisa Pleyer. I'm from Salzburg, Austria, from the Paracelsus Medical University, and this is my 2nd time here at this great meeting, and it's been a wonderful experience.
Hi, I'm Andrew Brunner. I'm from Massachusetts General Hospital in Boston, Massachusetts, United States, and it's been a real pleasure to chat with everybody about some of the challenges we have in MDS and some of the advances we're making over the last few years.
Hi, I'm Yasushi Miyazaki from Nagasaki University, Japan. I really enjoyed the 2 days iwMDS workshop. I would like to thank organizers for inviting me here.
So thank you so much for joining us here today. So maybe I will start with Dr. Miyazaki. Everybody in this workshop gave a talk, and I wanted to kind of get a quick summary, like a couple of minutes summary about the talks that have been given. So maybe we can start with you.
Okay, thank you. I talked about the general situation of allotransplant in Japan and our study regarding the conditioning intensity for lower risk MDS patients. In Japan, because we have a lot of cord blood sources, 1/3 of allogenic transplant is performed using cord blood. This is going to be one of the specific feature of transplant in Japan. In terms of the intensity for lower risk MDS patients, we found that reduced intensity conditioning has better GVHD-free, relapse-free survival compared to myeloablative conditioning. This information will be helpful for patients who's gonna receive allotransplant in the world. However, considering the number of transplant or the proportion of patients who can receive transplant is still limited. So we need to explore the safer and easier way for transplantation.
Thank you so much. That's great. Andrew?
Yeah, it was a real pleasure to be here and get to talk over the last few days about MDS and many new therapies that we're developing, as well as understanding some of the studies that have just completed. I think that what I was asked to speak about was really how we understand our communication about efficacy of trials. And this is really relevant. When we use a new drug or when we're trying to develop a new drug, one of the first things you're trying to do is show that there is potential, that this can beat our current standard of care. And then we want to show that this is meaningful in some later comparison. And in MDS, often we're not always speaking the same language. And I think that we as a group are in a unique position to try to advance both some aspirational goals. How do we find activity of a drug? How do we find activity of a compound that is really meaningful, maybe enhancing blood counts or looking at novel response mechanisms? At the same time, when we talk about trials, we need to make sure that they can talk to each other. It's a little bit like the Rosetta Stone of MDS. We need to be able to say that one trial can relate to another. And sometimes the way we've published our studies and the way we've reported out our outcomes hasn't always allowed a very easy comparison between trials or to historical controls. And so one of the goals that we have from this conference is to develop a set of minimal criteria that we can use in the future as sort of advice for when you're running a trial. Sure, we want to know exciting potential activity of a drug. We want to know ways in which it might change. Responses might change our perception of what we historically perceive. But we also want to be able to relate these drugs to existing criteria. And so can we as a group come together to say, here's some minimal criteria that we should use so that we can kind of interrelate drugs, find things that both beat historical expectations and have promise for the future. And so hopefully that's a real tangible endpoint that we can develop out of our meeting here this weekend.
Yes, so I was asked to talk about response criteria, and in the first part of my talk, I focused on comparison of response criteria in patients with MDS, AML, and CMML. And we're in the lucky position to have a large database that currently has more than 2,800 patients, and we're about to include data from a further 500 patients. So we're able to directly look at these comparisons on a patient level. And what our data showed was that IWG composite CR from the 23 criteria published by Dr. Zeidan's group is basically not only able to distinguish patients with the best prognosis in MDS or high-risk MDS, but this goes through for low-risk MDS, CMML, and AML patients as well. The second part of my talk focused on trying to find a new response criterion where you don't necessarily need bone marrow evaluation parameters termed peripheral blood complete remission. And we have already published this data, but we want to move on to the third part of my talk where we focused on guaranteed time bias or immortal time bias and ways how to eliminate this. So what we are going to focus on in the next weeks and months is eliminating this bias with AI methods and using all of the sequential data that we have with LSTM models. So we have about 45,000 differential blood counts entered into our database and a further 40,000 data points of other lab values, of quality of life measures and other things, ECOG, that we want to all merge into this model to find out which values, which parameters and which values thereof are really important and essential for prognosticating outcome in these patients. And that's work in progress.
Yeah, and that's actually very important because, we had a session during this meeting with the FDA, and actually they did emphasize the importance of validating these response criteria. So I think your work will go a long way, along with some of what was suggested by Andrew about validating these and hopefully within the context of the multiple phase 3 trials that have been conducted. Elizabeth, you covered oral hypomethylating agents, which I think are very patient-friendly approach of delivery of drugs.
Yes. So, I was invited again to speak about an update on where we stand with oral hypomethylating agents. And I think a lot of us were hoping that with this new data coming, that we would have a new standard of care, which would maybe replace single-agent hypomethylating agents. And I think, unfortunately, what we found now with Validate reporting negative data is that hypomethylating agents remain our standard of care at this point. And so I think it's really incumbent upon us to optimize utilization of hypomethylating agents for our patients in order to minimize toxicity, minimize time toxicity, as well as actual toxicity. And so we touched a little bit on some of the data using these agents, both in the first line and the real world setting, which demonstrates them to be, I think, at least as good as our standard parenteral approach, and potentially implementing these therapies in the post-transplant setting as a mechanism of forestalling relapse, which is really our long-term problem in these patients, hoping to get a large percentage of our patients to transplant.
Perfect. That's great. And just to give additional context for this, for people who don't follow the field very closely, just before this meeting, like a couple of weeks before we came, the results of Verona trial, which is the randomized phase 3 trial of aza-ven, which was the last standing phase 3 trial that, everybody was waiting the results for, were announced to be negative. We still have not seen all the details, just the press release that the primary endpoint, which is overall survival, was not met, which clearly was frustrating to many of us who treat patients with MDS and particular high-risk MDS. And this was extensively discussed in the meeting. Of course, I think once we see the full data, it's going to be much more informed discussion. But despite the frustrations, I think there is a lot of excitement about what we can do to move the field forward in high-risk MDS. And in that context, actually, I gave a talk about some of the immune checkpoint inhibition and some of the new directions that we are seeing beyond the traditional PD-1, PD-L1, CTLA-4, the traditional immune checkpoint inhibitors that have not done very well in the context of myeloid malignancies, but some of the novel agents looking at TIM3, a new way of targeting CD47, as well as a new immune checkpoint inhibitor going after Cleaver-1, which is a macrophage basically receptor, are showing actually promising data, including some very interesting 6 differential impact of sabatolimab, the anti-TIM3 agent, which we are trying to understand better, and how can we use this data to kind of move the field forward. So I think more to come, hopefully, in the near future.
Well, I'd love to comment on that if that's okay. I think there were some of us in the field who were very enthusiastic about doublet therapeutics with venetoclax combinations. And I think some of us who are a little bit less enthusiastic. And I have to put myself among the less enthusiastic group, in part because I saw a lot of toxicity associated with venetoclax implementation early on in MDS therapeutics. And I think fundamentally it speaks to the differential biology of the MDS disease state compared with the AML disease state. And I think, however you want to think about it, venetoclax plus hypomethylating agent is really a cytotoxic regimen, right? It's predicated on the ability to induce apoptosis. And I think when we think about disease status in MDS, these patients are perforce individuals with a slower disease cadence and therefore less proliferative underlying disease biology. And so it's not surprising, in my view, that this sort of cytotoxic nuclear bomb type approach, as we've shown before with chemotherapy, with other agents, is less effective in this disease state. And so I think instead of pushing for these very cytotoxic upfront therapeutics, I think an approach that really capitalizes on the things that we're starting to understand about the underlying disease biology and the immune dysfunction within that context are more likely to show us improvements. I mean, I think the fact of the matter is that allogeneic transplant remains the only potentially curative strategy for this disease, says that immunotherapy is likely to be the key there. It's the tickle, right? It's the small signal that we have for how to cure this disease. And I think what we can say is that that's the only therapeutic modality that's shown real promise, real success. And so we have to build on that.
But I would also like to comment on that. I mean, I agree with everything you have said, but I think the results of the trial, and that was also discussed in this meeting, which I thought was very interesting, they don't really give us the final results yet, because a third of the patients that were included had less than 10% blasts.
Absolutely.
And also perhaps the dose reduction scheme. So I think in MDS, most regimens are more toxic. So maybe you need to reduce the dose even more when you start. And when they did the dose reductions, they mainly reduced the AZA backbone in the 3 steps first. And I think for the azacitidine treatment, you should not, well, that's what the data from our registry show, we haven't published it yet, but is that you shouldn't really reduce to less than 5 days, full dose, and then you should stick with the 4 weeks.
4 weeks, absolutely.
So I think that perhaps that was also, so we don't really know quite yet. So I'm not all of it. So that would be interesting for me to know, in addition to what the trial has shown.
And I think this is very important because, critical. We still have not seen, the data of, in terms of what led to the failure of the trial. But I think, in my opinion, I think it's actually a quote from Einstein that, doing the same thing, or the same experiment multiple times and expecting different results is the definition of insanity, right? So I think we really have to learn from these negative trials about what was the problem. And from each negative phase 3 trial, I think we have learned something. So especially that there's actually what we have learned over the last couple of months, that there's already a phase 3 trial of another PCL2 inhibitor with an overall survival endpoint that seems to actually have a sample size even smaller than Veron. So I think it's very important to understand exactly what went wrong with Verona and how it would inform the other trial, because certainly nobody wants another phase 3 that will be negative. But maybe I'll go to you, Andrew.
No, obviously we could all talk about this quite a bit. I think it's a great reminder that MDS is extraordinarily heterogeneous and that different patients need different things. And some patients do need blast reduction, and that will yield blood count improvement. And some patients really just need transfusion independence, and some patients really need more platelets. And I think that a challenge, and this is a kind of a good reset maybe in the field to say, how are we designing our studies? Is risk, which is largely defined outside of therapy, should that be more affiliated with therapeutic intervention? Because when we assign risk, we kind of are saying, I'm going to treat you one way or another. So I'm either going to put you on a strategy of chemotherapy, potential transplant, I'm going to try to modify your disease, or I'm going to let you live with your disease and we're going to try to support your blood counts. And maybe there's some people with molecularly high risk disease that would really benefit from luspatercept or imetelstat and not trying to do chemo and transplant. And maybe there's some people with lower risk disease, which really we should do a different approach where they would be more responsive to traditionally high risk approaches. And I think that realigning to try to identify maybe in the future who best responds to a given treatment strategy rather than what's likely to happen if we let people just coexist and not do anything. That may be a way to really kind of advance forward and how do we design trials next? Because if we keep doing the same thing, I agree with you completely. We're choosing a pretty broad group of people to put onto one treatment. We put them on that treatment forever, and we see what happens in a few years. And I think that we can be a little bit more selective if we think about it in a slightly different angle.
Yeah, I agree. Through talking about the Verona study, we had a lot of discussion regarding study design, as you see, selection of patients, and how about the endpoint, overall survival? Did we have enough number of patients? Or many discussions we had. And as you said, MDS is a very, very heterogeneous disease. And killing cell therapy policy is not a good one. Of course, we have to change disease history. So, for example, azacitidine is a disease history modifying agent. And now we understand that imetelstat also can change the history of the disease. With the high risk molecular pattern, but we know that in the higher risk MDS molecularly, they are still heterogeneous. So I think we need to learn more about the biology of MDS. We just separate higher risk and lower risk, but that will not be enough. We have to separate them based on not only by genetics. Probably we need methylation status or others. But I agree with all of you. We need to more about MDS itself.
Dr. Miyazaki, I actually wanted to follow quickly on that point because you asked a very important question during the workshop. And this is something that I have seen actually come up more and more in AML trials about, they have this risk stratification by geography. And I think it reflects both understanding that maybe the underlying biology and genetic differences between different continents, Asia versus, highly Caucasian population, maybe in the US and Europe, but also different practices in terms of how you treat patients and different approaches. We still have not seen this kind of play out in MDS because largely the trials have been kind of negative. But I think what happens with many of the phase 1 trials is that they kind of primarily accrue from the US and maybe somewhat from Europe. And then once they go to the phase 3, this is when you have significant accrual from East Europe as well as China and potentially Japan, etc. So I wonder how, in your opinion, this plays out, not only for high risk, but I would even add for lower risk, because in lower risk MDS, we had a lot of discussion about the transfusion thresholds and, people were arguing 8 versus 9 versus 10. And what I actually discovered during a visit to China a couple of years ago is that they actually transfuse patients for hemoglobin of less than 6 or 6.5. So they are even much more restrictive than anybody, kind of us here in the US. I don't know what's the threshold in Japan, but how do you view these differences between the continents?
Okay. I talk about the CML. CML is BCR-labeled disease, and all over the world, imatinib TKI works very, very well, and we can get the same results
Okay. That's
Right.
exactly.
And
because
the,
we have an effective drug.
but the transfusion things were those not completely defined by only one genetic mutation, for example. It's very difficult to deal. We didn't discuss much about the social economy situation of patients, which can affect the results of clinical outcome. So we have a lot of factors which affect those things. In Japan, actually, we transfuse hemoglobin around 8 or something like that. And Dr. Sekeles told their study about the academic institution start to transfuse around hemoglobin level 8 in United States, I think. So that's a very similar one. So of course, it depends on the condition of institutions or hospital, academic or community hospital. Community hospitals start to transfuse around 10 or something. So that's the difference. That is not for patient factor. That's a factor of institutions or hospitals. So there are many confounding factors, I think.
I would like to briefly follow up on your statement or the question regarding why do phase 3 trial results not reflect phase 2 trial results? Well, I think that's a classical example of guarantee time bias, because in phase 2 trials, you often have overall response rates or CR rates as endpoint, where you have the classic lead time bias. And then when you look at overall survival in phase 3 trials, in the phase 2 trials, due to the guarantee time bias, you're overestimating the effect of the drug. That means you're underestimating the number needed to treat for the phase 3 trials. And that's perhaps why they are negative, is because you're not including enough patients based on the phase 2 trial results.
Yeah, and I think I think all of us are looking forward to seeing kind of the full results of Verona, but I think there will be a lot of what I would call post-mortem, like in terms of Verona and all the other trials and how we can move like going forward. But thank you so much. These are wonderful insights, and I would like to kind of thank the panel and thank everybody who participated in this largely like really international workshop that initially started with a smaller group of US-based physicians and then extended to Europe, and now we have representation from Asia and from Australia, and we are hoping to extend to South America and Africa. And I think it's very important to understand globally for MDS and MPN. And actually this year we started also live streaming of the workshop. We had many people who watched remotely, and the sessions have been recorded, and at one point they will be put online for those who are interested to kind of see the full discussions that took place. And I would end that our next workshop is going to be actually next year on October 2nd through the 4th. And we hope to continue to grow and maybe see some of you over there. And thank you so much.
Thanks for tuning in to today's episode. For full coverage from the iwMDS iwMPN's meeting, head over to VJHemOnc.com. And don't forget to follow us on X at VJHemOnc and subscribe to our podcast on Spotify, Apple, or Podbean. Until next time.